So first of all, it's a great pleasure to be here, and I would like to thank Reinhold Knecht and Wolfgang Stöttner for the invitation. I was asked to talk about the anti-EGFR treatment in head and neck cancer, so we'll try to summarize that to some extent. As you might expect, we had already a talk with Dr. Gerald that there will be some overlap, most probably, with what he's going to say, but he's going to be more in-depth about the radiotherapy aspects than I will do. Let me see if I can go forward. Right. Well, as you know, we are living in a very nice time where we have a lot of new molecular approaches, which are summarized to some extent on this slide. We are going to focus on the anti-receptor antibodies and on the tyrosine kinase inhibitors dealing with the effects on the epidermal growth factor receptor. So, first of all, the family of the four tyrosine kinase receptors, including EGFR, play a role in signal transduction that is critical for the fundamental metabolic and physiologic cellular processes, such as growth, development, differentiation, and death. Now, as you see on the next slide, the expression of the receptor is high in quite a lot of tumors, as you see here. And just focusing on head and neck cancer, you see that nowadays we assume that at least more than 90% of the head and neck cancers have a high expression of EGFR, or at least they express it. And it's known that the high expression in general is associated with poor outcome, especially related to chemotherapy resistance. They may also have resistance to radiation, are associated with late-stage disease and with metastasis, and in general poor outcome, as you see here. This is illustrated on this slide, where you see that the high levels of EGFR and of TGF-alpha result in a reduced disease-free and overall survival. You see this illustrated for EGFR here and TGF-alpha on the right side. Now, different therapies can be discussed. The largest experience is with the two on the left, the monoclonal antibodies, which are having an effect on the external domain, and the tyrosine kinase inhibitors, the small molecules that have an effect on the signal transduction and blocking the information from the receptor to the nucleus. But also toxin conjugates and antisense approaches are being tested. The importance of these monoclonals, like it has been shown for cetuximab, is that it seems to synergize our cytotoxic agents like the platinum compounds, and you see this here in an xenograft model with a human squamous cell carcinoma cell line, where you see here the effects in the control group without any treatment, cetuximab alone and cisplatin alone, and then the combination of both, which clearly shows that there seems to be a synergistic effect, which also translates in a better survival. And similar observations have been observed with respect to radiation, where cetuximab synergizes the effect of radiation also in this xenograft model bearing a human squamous cell carcinoma cell line, where you see that the combination of both is leading to a clear reduction in tumor. Now, if we focus on those agents that are more advanced in their development, and especially where phase 3 trials are being done, then you see that you have some monoclonal antibodies and you have some small molecules, as you see here. Now, of course, the phase 3 trials are not always in head and neck cancer, but I highlighted them in another color where they are involved in head and neck cancer. So cetuximab is, of course, launched for colorectal cancer, but it is being tested in phase 3 trials also in head and neck cancer, as you see here. Panitumumab is now in a phase 1 trial together with chemotherapy in the neoadjuvant setting and in chemoradiation. Gefitinib is in phase 3 trial in head and neck cancer. Erlotinib in phase 2, and lepatinib in randomized phase 2 also. So what are the data to suggest that for head and neck cancer this may have some importance? And this slide is summarizing the data that we have on cetuximab in combination with chemotherapy and with radiation, and also as a single agent. So there were patients initially who had platinum refractory disease, as you see here. They received either cetuximab alone or in combination with platinum. And there were 3 studies. 2 of them have been published recently in the Journal of Clinical Oncology. The third one is submitted to the same journal. And I will show you the data in a minute. The second group is the patients with recurrent metastatic disease with platinum-sensitive disease. And there you have randomized trials, platinum-based chemotherapy plus or minus cetuximab, US trial, and a non-randomized study which was presented at ASCO, and a randomized trial which is just completed in the end of December last year. And then we have, I think, for the discussion, a very important paper which is submitted to the New England Journal on the interaction with radiation in locally advanced head and neck cancer. So the first group of trials that have been done in platinum refractory disease, you see outlined here. So basically they all use the same schedule of cetuximab with 400 milligram per meter squared initially, and then thereafter weekly 250 milligram per meter squared weekly. And there is one trial where the drug was used alone, as you see here, but then when patients were progressive, they could continue with cetuximab plus the platinum compound they had been using before. And in the other 2 trials, they used cetuximab with cisplatin or with carboplatin, to which they were refractory. And what we did is we compared these data with the data from the literature where they used standard medication for such patients, like chemotherapy or radiotherapy. And we looked whether there was a suggestion of an improvement here. And what you see is that both with cetuximab alone and with the 2 trials where it was combined with platinum compounds, you see that the response rate is from 10 to 13%, which is really much better than what is found in the literature in this retrospective analysis. Also, it is important to realize that apart from the responses, that quite a lot of patients have stabilization of disease, which may be of benefit to them. And this increase, of course, the clinical benefit, which is a sort of definition that is, of course, being used when you don't have too active medication, but still seems to be promising for the patients. With respect to survival, the normal, you could say that patients who are resistant to cisplatin, when they have recurrent or metastatic disease, the median survival is in the range of 4 months. The suggestion here is that it is somewhat better in these trial patients, whatever that may mean, but if you compare that with the retrospective analysis that we did, that seems to lead to some improvement. Now, in patients with platinum-sensitive disease, we have 3 trials here. The one by Burtness, and this was a small randomized phase 3 trial where platinum with cetuximab was compared with platinum plus placebo. There was a difference in response rate, and there may have been a slight suggestion of an improvement in survival, but this was not significant. And most probably the reason for that was that this trial was not large enough to show this. At least that's what I hope. The second trial, which was presented at ASCO, is only important for the knowledge that cetuximab can be combined with our standard medication, that is cisplatin 5-FU or carboplatin 5-FU, is leading to the expected response rate. Cannot say whether it's any better or not. And the median survival is somewhere in the range, but on the higher range, I would say, of what you normally see of 6 to 9 months. And then the trial that was just closed is a large trial, as you see here, in total 442 patients, which were included in 1 year time. It was a fascinating trial. There is an ASCO abstract on the early interim data by a committee that judged at that time whether the study could continue as a sort of interim analysis. So the final analysis most probably will not be, we will not be able to present. But here the primary endpoint is a survival benefit. What is important for using this monoclonal is the fact that it does not seem to enhance the effect of the cytotoxic drugs with which it is combined, at least for the platinum compounds. You see here it's not unexpected what you see here with platinum alone or platinum with cetuximab. Of course, the importance is that skin reactions, and now we are talking here about grade 3 and 4, so it seems to be mild, but a large proportion of patients have skin reactions. Only a minority of them are severe, as you see here. Still, there is one patient that had a striking hypersensitivity reaction in the trial where the drug was used alone, and this patient died. So it is still something that we have to take into account. It's not completely without any danger. Can I have the next slide, please? Yes. Now, concerning the other drugs, you see here data for gefitinib and erlotinib. There was a suggestion from 2 trials that there may be a dose effect. With the higher dose, there is a somewhat higher response rate with cetuximab 500 milligrams in comparison to the study where they used this lower dose. Then there was a recent publication that suggested that the combination of gefitinib with a COX-2 inhibitor at the higher dose, in this was originally a phase 1 trial, but with the higher dose you see in these 18 patients that 22% of them responded, which is quite promising. Then we have data on erlotinib, which is more or less in the same range as what you see here with gefitinib. And then there was this study that combined erlotinib with Avastin in a phase 1 trial that was originally presented at ASCO in 2004 and again in 2005, where in the phase 2 trial 11% responses were used when the highest dose in the phase 1 was used in the phase 2. Well, I want to focus now on the randomized trial with radiation. Which is a trial in locally advanced head and neck cancer.